Initially, the heart consists of a simple tube. It's anchored at one end by the differentiating arterial trunks, and at the other by extensive venous channels which drain into the atrium. Being fixed at both ends, the cardiac tube grows rapidly in length, and the embryonic ventricle is bent into a loop to the right of the midline. As development continues, the ventricular region swings back to the midline and expands and grows in length to cover the atrium and great veins. Extensive sacculations projecting laterally will ultimately become the right atrium and left atrium. The future left ventricle lies to the left of the interventricular groove, and the embryonic right ventricular or bulboconus region communicates with the truncus arteriosus. A four-chambered heart is formed from this convoluted tube by the development of three septa, partitioning the atria, the ventricles, and the truncus arteriosus. Although these septa develop simultaneously, they will be considered individually. By viewing the heart from the right side, partitioning of the atria and ventricles can be more easily visualized. Externally, a deep groove separates the atrium from the ventricle. Within the heart, the atrioventricular groove appears as a deep invagination, which constricts the atrioventricular canal at its waist. The canal becomes divided along its longitudinal axis by two partitions, growing from the walls of the two common chambers toward the auriculoventricular junction. Endocardial cushions extend from opposite sides of the atrioventricular aperture and ultimately fuse into a column dividing the channel between the atrium and ventricle. From the interventricular ridge, a proliferating muscular septum advances across the common ventricle toward the base of the heart. Simultaneously, the interatrial septum rapidly grows toward the endocardial cushions, progressively constricting the foramen between the atrial chambers, the foramen primum. Before the foramen primum becomes obliterated, a new opening appears high on the interatrial septum. The timely development of this orifice, the foramen secundum, provides uninterrupted shunting of blood from the right atrium directly into the left. Another interatrial septum, the septum secundum, develops from a ridge just to the right of the septum primum and extends down like a curtain over the interatrial fenestration. The advanced edge of the septum secundum forms the foramen ovale, with the septum primum acting as a unidirectional flutter valve. Thus, blood can flow only from the right atrium to the left. To recapitulate, the common atrioventricular canal is partitioned by the simultaneous proliferation of the endocardial cushions, the muscular interventricular septum, and the interatrial septum. The septum secundum produces the foramen ovale, with the septum primum acting as a membranous valve. An opening persists between the ventricular cavities. Closure of this interventricular foramen awaits the elaboration of a complex spiral septum, which splits the truncus arteriosus and conus region into the aorta and pulmonary artery. The formation of this partition is more clearly seen if the heart is turned by 45 degrees. Originally, the right and left ventricles share a common outflow channel, the truncus arteriosus, which gives rise to the aortic arches. The truncus arteriosus is presented schematically as a transparent cylinder. The bifurcation of the truncus arteriosus, illustrated here, represents two of the aortic arches. The fourth aortic arch forms the aorta, and the sixth is the origin of the pulmonary artery. A pair of ridges which develop at the bifurcation spiral down the truncus arteriosus. They fuse along the axis of the cylinder to produce a single spiral septum, extending down towards the ventricles. The interventricular foramen is obliterated by masses of endocardial tissue from the ventricular septum, by the endocardial cushions, and by the spiral aortic septum. The partitioning of the heart into its component chambers and corresponding arteries is now complete. The significance of the spiral aortic pulmonary septum is more readily appreciated in a frontal view of the heart. The aortic pulmonary septum executes a spiral of 180 degrees and swings into line with the superior margin of the interventricular septum. This process accounts for the manner in which the aortic and pulmonary trunks are entwined in the fully developed heart. Blood from the left ventricle enters the aorta, which passes to the right behind the pulmonary artery. Blood from the right ventricle enters the pulmonary artery, which passes in front of the aorta, turning posteriorly on the left side of the mediastinum. Venous blood from the superior vena cava and the inferior vena cava flows through the right atrium and into the right ventricle. It's ejected into the pulmonary artery, where a major portion continues through the ductus arteriosus into the descending aorta. Resistance to flow through the collapsed lungs is so great that only a small quantity of blood enters the pulmonary arteries. A correspondingly small amount of blood is returned through the pulmonary veins into the left atrium. Oxygenated blood from the placenta enters the inferior vena cava, but tends to stream across the right atrium through the foramen ovale and into the left atrium to supplement the scanty pulmonary venous return. This mixture of venous and oxygenated blood enters the left ventricle and is pumped into the aorta, from which the carotid arteries arise to supply the brain. Through the descending aorta, partially oxygenated blood is distributed to the lower portions of the body. This circulatory pattern persists throughout the remainder of fetal development. Within a very few minutes after delivery into the external world, the supply of oxygenated blood from the placenta is interrupted. If the infant is to survive, respiratory exchange in the lungs must be promptly established. As the lungs become inflated, the resistance to pulmonary blood flow is markedly reduced. Constriction of the ductus arteriosus diverts the entire right ventricular output into the pulmonary circulation. Oxygenated blood returning from the lungs is distributed through the systemic circulation. When the pressure in the left atrium exceeds that in the right atrium, the valvula is pressed over the foramen ovale, and partitioning of the heart is functionally complete.
Now we want to go back and look at the embryonic circulation once again, and we're going to talk about the aortic arches first, and then we'll come back and talk about the development of the veins. If we talk about the development of the aortic arteries into the great vessels, the major arteries, what we're going to do is use this little schematic. It's not quite right, but it'll make the point. And the point is that there are aortic arches that are going to connect the outflow region of the heart with developing dorsal aorta. These aortic arches are numbered 1, 2, 3, 4. The fifth one never really appears, that's why we show it in a dotted line, and then a sixth aortic arch. These appear sequentially, never all at once, but that's how we're going to show them, so we can just go through how these different aortic arches contribute to the great vessels. The heart would sit down here, and the outflow area would empty into the region of the aortic sac. So if we look at the aortic arches, we can then talk about how they contribute to the great vessels. Basically, the first aortic arch is not going to contribute very much at all. In fact, most of it degenerates. We could talk about a little bit of it remaining in the adult, but that's a minor consideration. The same thing with the second aortic arch. Very little contribution there to adult structures. Maybe a little bit of the hyoid bone artery. We're not going to fuss about that. The third aortic arch is what we're going to begin talking about, and the distal portion of the third aortic arch, along with the dorsal aorta, cephalically, are going to form the internal carotid artery. The proximal portion of the third aortic arch, plus this little bit of ventral aorta between the third arch and the fourth arch, is going to contribute to the right common carotid artery. And a new vessel that develops at the junction of the common and distal internal carotid is going to form, and that new vessel is going to be the external carotid artery. Note that this distal ventral aorta is going to degenerate. In terms of the fourth arch, there are different fates for the different sides. On the left side, the fourth arch is going to contribute to the arch of the aorta. So the aorta is formed by the truncus arteriosus and the fourth aortic arch, and then a little bit of the descending aorta down to the seventh intersegmental artery. The seventh intersegmental artery is going to contribute to the subclavian artery. On the right side, the fourth aortic arch, the descending portion of the right dorsal aorta and the seventh intersegmental artery are going to contribute to the subclavian. They're going to make up the subclavian artery, which we can see here. Notice that between the third and fourth arches, the dorsal aorta is going to degenerate normally. Also note that the ventral aorta is going to remain on the right side as it connects the aorta to the subclavian and the common carotid, and that vessel is going to be the brachiocephalic artery. So now you can see how the brachiocephalic, the left common carotid artery, and the subclavian are the first three major branches off the aorta, and you can see where they come from. As I said, the fifth aortic arch never really appears, so it degenerates. The sixth arch will contribute to the pulmonary arteries, right and left, at least the proximal portion. The distal portion will have different fates. On the right side, the distal portion will degenerate, along with the rest of the descending aorta on the right. On the left side, this distal portion of the sixth aortic arch is going to remain and will be the ductus arteriosus, and that will remain until birth and will shunt blood from the pulmonary trunk over to the aorta for the fetus. Now, if we turn our attention to the inflow area of the heart, we can talk about what happens in terms of the development of the major veins. And here, what we can go through is the development of the major veins, and what I want you to gain an appreciation for is the large veins and where they come from. So we can talk about the fact that there are common cardinal veins that empty into the heart, into the sinus venosus, and the common cardinal veins will receive blood from the anterior cardinal and the posterior cardinal. And that the anterior cardinal vein is going to give rise to the internal jugular, and the subclavian is going to arise as the corresponding intersegmental vein here that'll give rise to the subclavian vein, and then a new vessel will give rise to the external jugular vein. So the question is, where do the brachiocephalics come from? And here you can see that the brachiocephalics come from a little bit of this anterior cardinal that gives rise to the right brachiocephalic. The left brachiocephalic is a new vessel that forms called the thymicothyroid anastomosis of veins, and that will connect the internal jugular, the external jugular, and subclavian on the left over and shunt blood over to the right side. What's going to happen then is that we're going to get a degeneration of the anterior cardinal over on the left. On the right, the anterior cardinal is going to remain and is going to become the superior vena cava. And the posterior cardinal is going to remain and give rise to the azygous vein. And the coronary sinus is going to come from a little bit of that left common cardinal vein. So these are the structures and where they're derived from, the great vessels, the great veins. In terms of the inferior vena cava, it's a very complicated picture. And the reason for this is there is a lot of changing in the venous drainage of the body because of, number one, the development of the liver, and number two, the development of the kidneys, which is quite interesting as the kidneys are very large for a while and will then degenerate, the mesonephric kidneys. And so what we'll end up with is a rerouting of the blood supply here in the abdomen. What I would like you to remember is how the inferior vena cava develops. And so the inferior vena cava is going to develop from four different sources. Alright, the first source is the subcardinal anastomosis of veins. These are the subcardinal veins, and on the right side they're going to give rise to what we're going to call the renal portion of the inferior vena cava. So the renal portion of the inferior vena cava is from the right subcardinal vein. The part of the inferior vena cava behind the liver, the hepatic portion of the inferior vena cava, arises from a new vessel that develops behind the liver and connects the subcardinal vein to the right vitelline vein. And so the hepatic portion of the inferior vena cava, which is actually this yellow area here, the line hasn't been completely reached that yellow area, but that yellow hepatic portion of the inferior vena cava then develops from this new vessel. And the rest of the inferior vena cava proximally is from the right vitelline vein. There's also a postrenal portion of the inferior vena cava, and that postrenal portion arises from these posterior cardinal anastomoses. All right? Some people would suggest, if you read them, from these sacrocardinal veins. That's another term, or some people will call these supracardinal veins. So we have three different ideas about how this portion forms, and we can just say that it's the distal supracardinal vein or the posterior cardinal anastomoses that help form this distal portion of the inferior vena cava. In addition, then, the posterior cardinal anastomoses is also going to give rise to the common iliac vein. Now, in terms of the portal vein, here we have the foregut, and we're showing the vitelline veins and the umbilical veins. And we want to make the point that the portal vein develops from the vitelline veins. And you're going to see that these vitelline veins form the anastomoses between each other, and that those will come together and form the portal vein. So there's the vitelline veins in green, and they will form the portal vein. In orange, we're going to have this particular area, the proximal vitelline veins, and they're going to form the hepatic veins. And in between, these cells are going to be broken up, these vitelline vein cells, and give rise to sinusoids of the liver. The hepatic veins are going to end up connecting with the right vitelline vein to empty into the inferior vena cava, which you see here. In addition, we can talk about the umbilical veins and note that the umbilical vein on the right side is going to degenerate because of the growth of the liver. So we'll just end up with a left umbilical vein, and that will continue to the liver, and then there will be this new vessel that forms, and that's called the ductus venosus. The ductus venosus will form a bypass, whereas maternal blood can go across the umbilical veins through the ductus venosus, bypassing the liver to reach the inferior vena cava. In the after birth, the umbilical vein will degenerate as blood from the placenta ceases. It will form the ligamentum teres. And the ductus venosus will cease to be functional and will become the ligamentum venosum. So we can now talk about what happens as the fetus is born. Fetal circulation, the blood comes from the umbilical veins. It goes through, it's actually just the left umbilical vein after a while. It goes through the ductus venosus to the inferior vena cava. From there, it can go in two different directions. One, that blood can go from the right atrium to the right ventricle to the pulmonary artery, and then most of that blood will go via the ductus arteriosus to the aorta and out to the systemic circulation. A little bit will go to the pulmonary artery. The other pathway that can be followed is blood from the ductus venosus can go to the inferior vena cava in the right atrium, and then, as we said in a previous lecture, go across foramen ovale to go to the left atrium, the left ventricle, and out the aorta. Now, what happens at birth? At birth, the umbilical vein is going to cease receiving blood from the placenta, It then is going to close off along with the ductus venosus. In addition to that, we're going to have the closure of the fossa ovalis, and that occurs as the left atrial pressure increases, supersedes the right atrial pressure, and fossa ovalis is closed off. Finally, as the blood supply now changes and the right blood supply, right side of the heart is supplying the lungs now, and there's more blood than that needed to go to the lungs, the ductus arteriosus is going to have to close off. So that we'll end up with blood from the inferior vena cava going to the right atrium, to the right ventricle, to the pulmonary artery, to the lungs, to the pulmonary veins, left atrium, left ventricle, and aorta. So these four structures in red are all going to have to degenerate. So at birth we get closure of the umbilical vein, closure of the ductus venosus, closure of the foramen ovale, and the ductus arteriosus is going to close. And that's going to close as a result of increased partial pressures, oxygen partial pressures. Bradykinins are going to be released from the lungs, and that's going to help. And the prostaglandins that are released prior to birth keep that fetal vasculature dilated, and the decline in prostaglandins then will also contribute to the closure of the ductus arteriosus.